what do you think the probability of this vaccine creating an I Am Legend type of scenario? I feel like
Dude,
that's the most
that's the most
problematic
important
part, right? Even
Yeah.
if the
I
vaccine
don't think
doesn't
it is,
create
though.
it,
I
it
don't
could
think-
evolve into something like that, right?
No.
I mean,
It's a
Can you explain the RNA technology for some people? I feel like they don't know what it is, though. If you know what.
yeah. So there's a few different vaccines, right? So the Moderna and the Pfizer vaccines
Yeah.
are both mRNA vaccines. So they contain mRNA, which is messenger RNA. So it's not DNA. There's other vaccines that they have, like the AstraZeneca one is a adenovirus vector vaccine.
I mean,
that
that I
second
think-
one's more likely to create zombies.
No, I think the second one's actually been around longer, so it's probably
Yeah.
proven that it's not going to do
Proven
that.
longer,
maybe
yeah.
maybe the mRNA one. I mean, I don't. I mean,
No.
you know,
Alright.
in all reality, I'm very very doubtful. But if it
Yeah.
does happen,
I
you
don't
know,
want
I'll
to be
let you
Will
know.
Smith.
Hey there. Welcome to the Gluten-Free Organic Thoughts podcast, where you are encouraged to express your natural thoughts and views through casual, meaningful conversations that hopefully can lead to learning and understanding new perspectives. To find out more info, visit www.gfothoughts.com. Now, here are your hosts, Michael Wong and Robert Din. We hope you enjoy this episode.
Hello, everybody. Welcome back to another episode of Gluten-Free Organic Thoughts. My name is Michael, and with me, we have a special guest today, Adnan Javed. He is an ER doctor out of Gainesville, Florida. And always with me, Robert Din.
What's up, everyone? Dr. Adnan.
How's it going?
How's it
guys?
going?
It's been a while.
It has.
I haven't seen Adnan since college. Like, it's been a long
Yeah.
time.
Yeah, college was a long time ago too. Like now that you mention it, that's like 10 years ago.
Right? Yeah.
I saw you last year, right? I saw a year ago.
Yeah, I saw you. You came and stayed here actually.
Yeah, but
Yeah.
it's been a year though, right? I'm pretty sure.
Yes. Yeah. Good.
All right, so let's start off with the drinks. What are you drinking tonight?
I'm drinking my Noob Slayer instant espresso because I'm lazy.
Noob Slayer.
There we go. All right. I have some yerba mate tea brew. Two little basic yerba mate tea. You know,
Basic Mike Wong.
basic.
I have a cab that I'm drinking today.
Nice.
From Argentina.
Ooh,
Yeah.
it's probably
Yeah.
dry, right? It's really dry.
Pretty good. Yeah, it's pretty good.
Nice. All right. Well, let's get started. We have a lot to cover today. Well, appreciate you, hopping on. I know you're busy, taking your day off, from working a lot. I'm sure last year, between this year, has been crazy for you since you're in the ER. Tell us a
Yeah.
little bit more about that. How, when the beginning, how crazy it was, how
Yeah.
you all end up adjusting. Give the nasty detail. at us
Wait,
today.
how long before COVID were you in the
Oh yeah,
as
sure.
a
How long you
ER?
been this for? Yeah.
Yeah. So I did my residency in emergency medicine from 2014 to 2017. So I graduated that, and then I went and worked. I lived in Boston and worked in Worcester. I worked for UMass, kind of in an academic, assistant professor role. That was my first job. I did that for a year. Then I moved back to Florida and was actually working in Georgia as an independent contractor doing private practice at a hospital in Georgia. So I was commuting.
Oh, from Florida to
And-
Georgia.
Yeah. So I would actually, I wasn't commuting every day. I would go and stay there for like a week and work.
Hmm.
So I had done about 2 years out after residency. So a total of 5 years, I guess, spent in the emergency department. And then now I'm doing a critical care fellowship, which is a 2-year program so that I can get board certified in that. So I'm
Nice.
towards the tail end of that. Yeah.
So what's next after this?
After this, I think I'm definitely done. Like with in terms of training, I'm not gonna do any more training. I'm just gonna get a job and work and work on my
Make
career.
more money. Got it. Yeah.
Yeah.
Still in the ER?
So yeah, it's a good question. I think I'm gonna do a little bit of both. I think starting out, I'm gonna devote most of my time to the ICU,
Yeah.
especially because it's like COVID right now, and
Yeah.
there's more demand for people, I think, to work in these intensive care units, and I kind of want to hone my skills in that since I haven't done that as much. And then I'll do some ER work, but I want to keep it primarily ICU for now.
Gotcha. Nice.
Yeah.
So tell us a little bit more about, last year, the beginning of last year, I guess March. I'm sure things start flooding in probably maybe during the summer, right? So just tell us, tell us where you were at, I know you were bouncing back a little bit between Gainesville and Jacksonville. You stayed in Gainesville for a little bit.
Yeah, so I was, when COVID started, I was a full-time fellow here in Gainesville, and of course, not in hindsight, I'm super glad I did the fellowship because when I started, there was no pandemic, incoming pandemic or any of that, and then once it started,
was it very calm for you?
Yeah, I mean,
for
yeah,
ER, for ER is very calm.
yeah. I think are you talking about like when COVID started?
Yeah.
Yeah, I think it kind of hit everybody by surprise, but it was definitely like, the other thing you have to remember is I'm in Gainesville. So Gainesville is not a highly, high population density kind of area. I'm sure that if I was in like
a big
New
city.
York or like Detroit or, somewhere where I could have been doing critical care out there.
Yeah.
Even St. Louis, where I interviewed, and I almost went there. I think things would have been way different. But
of course,
Gainesville, small city. Most of our patient volume comes as referrals and transfers from other hospitals. So, I never expected that we were going to see like massive, like overrun hospital systems.
Flood.
Yeah, exactly. Like they were seeing up north in these cities.
Yeah, in LA, bigger cities like that for sure.
Yeah.
So. So the beginning, I would say the beginning of when people started taking everything serious, was probably March. And March is, I think, when the CDC started saying things like, okay, we don't have enough PPE. I think that's when people were like, oh crap, this is like real, like this is a big deal, because even up until February, it was like, oh, we only have like 2 or 3 cases, and not to get into the politics of it, but I think that at least the message from the government was very different than I think what it was in March. I think by March, everyone was like, okay, things are
serious.
Yeah. So March is when I think we started getting guidance from CDC and the Centers for Medicaid and Medicare Services, which is who basically does billing for the entire, healthcare in the United States. And they were like, okay, so we should probably start thinking about like cutting down on elective surgeries. You probably need to start conserving PPE. You probably need to like really massively overhaul the system to prepare for what's going to be an influx of patients. So that was in March, and then it never really happened. Like at least, so we never, like we were waiting, like basically everything was shut down. Like they weren't doing any of these like, hip replacements, all these elective surgeries, and the hospital system was essentially shut down. The city was kind of shut down, and ER volumes were dropping off. Like,
for like 2-3 months, right?
Yeah. So between like March and May, maybe like for that 2 months, it's like, everything was shut down. And except for these essential things, in the hospital.
Yeah.
And that sort of influx we were expecting, where we were gonna have enough ventilators, like all that stuff. It didn't happen. It didn't happen here in Gainesville. It did start happening a little bit in August, like July, August is when we saw like, okay, wow, now we have like 10, 15 people who have severe COVID, like they're in the ICU, they're very, very sick. And I would say that's when the system started to get a little bit tested,
Okay.
And then since then, it's kind of been like an up and down kind of wave, where things calm down again, but then like right around the holidays and after the holidays, it sort of picked up again, and I think we're sort of, I don't know if we're in equilibrium yet or not, but.
I think also Gainesville is a lot, obviously, there are enough residents there, but I think because not having students, that kind of helped, right? Because a lot of them are remote. So
yeah, absolutely. Once they shut down campus, in school, which I think starting in March, up until now, pretty much students are back now. That was a huge deal. I personally enjoyed so much of it because I was like, you can get to work in like 10 minutes.
No traffic.
Yeah.
There's no traffic. There's no annoying people.
Because Gainesville is mostly a college town. So
it is,
without the school, like there's nobody there.
Yeah. It's at least, you can argue it's at least like 50-60% like.
Yeah, for sure.
Yeah.
So when did this fall, this last fall, right? They started having students back, right?
They actually, so I think they did initially, and then they kind of shut it down again. Like, I haven't kept up with all their emails because like I just get like 1,000 emails from the university. I just delete them all. But I will tell you, even last fall, like I didn't feel like there was still like much of a student volume back here.
Okay.
I think you had some, but then they shut it down again. I think because numbers started picking up. Now though, now that we're in January, now I think everything's open. Like because I go out to where all the undergrad sort of bars are and stuff, and it's like there's packed.
You see them hanging around.
Oh yeah.
It's packed up.
It's back in swing. Things are back in swing.
Wait, so the bars are open up there?
Yeah, they are. They're
really
completely open. Yeah, completely open.
So I guess let me ask you this. Obviously, like people are hanging out, stuff like that, and up to the holidays, have you guys ever felt, really like, okay, the system's getting overwhelmed, or it's just busy enough? Like,
Yeah, yeah. There's I would say, and again, it's hard because I haven't been in the emergency room consistently, but
Yep.
the emergency room is where you can feel the pulse of the whole hospital. Like if you really want to understand what the healthcare system is like or what the resources are and kind of how the hospital is functioning, you just go to the ER. Because if the ER is packed and there's like people waiting like 20 hours to be seen, that tells you that everything in the hospital is slowed down too. That means they're not moving beds. That means patients are not getting discharged. That means things have just kind of slowed down and you're at a bottleneck.
so you're getting so pretty much you're getting backlogged.
You're getting backlogged, and the ER is the first indication of that, right? Because the volume coming to the ER is pretty consistent, for the most part. So it's happened a few times. I would say, I worked in December, and there were times when I went into work, and like usually when you come into the morning, like you come into the morning in the ER at like 7 a.m., 6 a.m. It's usually very, very empty. There's like nobody in the lobby because we've cleared everything. We've seen everybody
At that time, yeah.
by that time. But if I come in at 7 a.m. and there's 40 people in the lobby, that's a big problem. And
Jesus.
that's what was happening. And I was like, that's crazy. That means that like there's no beds in the hospital.
Wow.
That's crazy.
So that's happened a few times. Yeah.
Even with the expansion of Shands, Jesus.
Yeah, even with the expansion of Shands,
Wow.
because they haven't really expanded the ER and they haven't really, a lot of this is process improvement. Is like
that's part of it too, though. Obviously, yeah.
Right. I mean, I compared like Shands Jacksonville, which is a much poorer hospital technically. Like their payer mix is not good. Like they're not getting reimbursed for half the stuff they're doing.
Yeah.
Whereas here they are. Like people coming here in Gainesville generally have better insurance. But Shands Jacks does a much better job of, in my opinion, of process improvement and using what they have to like make things flow. And they just don't do that as well here.
Gotcha. So obviously every hospital runs run differently. Efficiency is run differently, probably though. That's probably what it is, though.
Yeah.
And I'm sure probably they'll learn from that. It's just a matter of time when. That's all it comes down to.
I hope so.
So are now elective surgery back to normal now?
Yeah, it's a good question. So yes, I think starting in May, I want to say late May, the university started, or the hospital started basically catching up to, opening up all their elective procedures. Okay. There's a backlog, obviously, but that's correct. Yes.
Yeah.
And are mostly, I know like a lot of people get transferred over to Shands Gainesville, right? Was most of the like COVID cases, were they transfers in, or were they just like in the community that were?
Yeah, initially they were the first COVID patient we had here in this hospital was a transfer from Georgia. And it's from the same hospital I still moonlight at. Like I still go there and work there. And so that's where the first patient came from, was from an outside hospital in Georgia. Not even the same state, it's kind of crazy. After that, the volume of sort of more native people here, or local people here, picked up. So right now it's mostly people from Alachua County or nearby, but we still have like a reasonable number of transfers. In fact, what we're seeing now, more of the transfers that are coming in now related to COVID are people who had COVID and they got better. They don't have active COVID anymore, but they have sort of permanent lung damage from having COVID, and now they need lung transplants. Wow. And UF here is trying to be like a big like lung transplant center. Like that's their vision. They want to get up to like 100, 120 lung transplants a year.
Wow, that's a lot.
So they're offering a lot of lung transplants to these guys.
Wow.
Yeah. Jesus. Where are they getting all these lungs from?
That's a lot of lung.
There's a lot of lung transplant. I'm like 100 a year.
Yeah.
I heard from this, I don't know from where. Isn't an average hospital do like maybe 10 lung transplants, something like that, or something ridiculous low?
Yeah. I mean, so lung is a relatively like recent kind of thing. Like people were doing lung transplants back in the 70s and 60s, I'm sure, but like the outcomes were like really, really bad because like lung is not. It's not technically a solid organ. Like, there's different types of transplants, and there's solid organ transplants like liver, kidney, been done much longer and a little bit less complex, I think, or a little bit more well established in terms of safety. Lung is like it's a relatively new thing, and it's also tied into the fact that ECMO. I don't know if you guys have heard of ECMO, but extracorporeal membranous oxygenation. It's basically like a machine that essentially can keep you alive even if you're basically dead. it can function as a lungs, it can function as heart. So the technology for that has gotten a lot better. So because that's gotten better, you can actually do these lung transplants, and even if they're not doing too well early in the postoperative period, you can keep them alive until the lungs start working and they're doing better. So I think that's part of why lung transplant has become more of a thing.
Gotcha. So, I mean, now let me ask you this. Obviously working in the ER, has it prevented you to see your parents a lot, family, things like that, just because, and how often you got tested? Just wondering.
Oh, that's a good question. Yeah. So I got tested. I've really only been tested a couple times because, for practically speaking, like exposure wise, I'm exposed all the time. So there's really no point in me getting.
I guess you're so used to it. Like you're so used to the exposure. Like you're already risking it, I guess, because you're in the ER.
Right. So the only time they were testing me initially was I got tested once because I had like a real exposure. Like I was cleaning, like I was doing something with a Foley catheter, which is a type of urinary catheter, and I messed it up, and the guy's like urine and blood went all over my face. So the guy had COVID. That guy had COVID, but he was not symptomatic. He was there for something else. So I got tested then, and that was pretty much it. And then I had to get like another surveillance test before I started working in the ER more regularly. So I've been very lucky. I've also never been symptomatic. I never got a fever. I never got sick with anything. I'm sure if I did, then I would have had to get tested. But
of course,
did anyone on staff have any symptoms or get COVID?
Oh yeah, all the time. I mean, so much of our staff got COVID. Like many.
Oh really?
Pretty much across all levels. Like lots of people.
I'm sure nurses, because they see that often. Yeah, of course.
Yeah, big problem.
So did you end up getting the vaccine too?
I did. So we have the Pfizer vaccine. That's what they've been giving us here. So I've already completed both doses as of like 10 days ago or something.
Oh, nice.
15 days ago. Yeah.
Did you get any reaction to headaches? Some of that?
Yeah. So the first day, the first dose, I don't know if it was a reaction or I was just really hungover. Because
the difference. There we go. Just drink the night before.
Yeah, no, I had gone out and like I go to this local bar here and we play like basically bar poker, not for real money.
Yeah.
I stayed out kind of late. That was the same night that I got the vaccine. So I woke up the next morning with like a headache, feeling really tired, nauseous, and I was like, I don't know, this feels like more than a hangover, but at the same time, it could have just been that.
Yeah, because I heard from a lot of people that the first dose is just the hand feels a little bit numb. That's about it. It's the second one that people feel some kind of headache, things like that. The dizziness.
Dude, I've heard so many different things. Like the second dose for me was perfectly fine. Like I had no issues with that. Other people told me that the second dose was terrible. So I don't know.
Gotcha. So at least that's good for you. That's good. At least you didn't get impacted by that as much, though. Yeah. That's awesome.
Yeah, I'm lucky.
No, I mean, a lot of people, I mean, tell you, like, in terms of like just, especially nurses, I know a couple of them already got COVID, and then obviously they decided to get the vaccine. A few of them just got some minor side effects, like, a little chills and stuff, but then it went away after a day or two, or they got some headache out of it. So it was nothing big, So.
Yeah, I mean, the trial for these for the vaccines, they're still ongoing. So, they're still going to do some long-term safety analysis. Hopefully, I hope so. I mean, they claim they are, but so hopefully they'll keep tracking people for like a few years. But
and obviously it's the long-term effects just in case any kind of reaction. So I mean, everyone's different, right? So you never know. Like, and then obviously they started doing priority-wise in terms of 65 and older, frontliners and stuff like that. And they just slowly kind of digress it down. So we'll talk about the vaccine a little bit more. But I'm curious because I want to talk about kind of like the repercussion of that. But moving on to so let me ask you, like, in terms of, I guess now the current situation right now, has a lot of your ER procedure changed, like in terms of like, or did it go back to normal now? Like, for example, like, just, hey, you guys have, this patients go to this side of ER, things like that. Or you guys, or because now they get started admitting normal people again, I'm sure you guys, differentiate that.
Yeah, that's a good question. It's the problem is that not a lot of ERs, of course, are designed for this kind of thing. None of them are, in fact. So initially they were like, oh well, what do you need? You need negative pressure rooms. And the only practical reason before all this that you had a negative pressure room was for people who had tuberculosis or you suspected
TB. That's right.
Suspected they had TB. So really, most ERs, like even a big hospital, really
they're not prepared for this at all.
No, they only have like 2 or 3 of those negative pressure rooms, maybe. I think we have like 2. Maybe period. And this is a big hospital. So obviously the ER was not designed for this. So then they try to do these protocols like, okay, so now, for example, like any patient that comes into the ER has to have a mask, even if they come in with the ambulance, like even if they're like almost dying, like coming, for a stroke or something, they have a mask on. They have to have a mask on. The EMS people have a mask on. So those kind of procedures I think they're going to stay for a long time.
No guests, right? Still, right? You can't have guests coming out.
Yeah, that's another good point. So they've relaxed some of that a little bit. Before it was like absolutely nobody, like no family members, no guests.
Unless you give it birth, as I heard.
Yeah. No, that's true. So they've relaxed that a little bit now. That if you're not COVID or not coming in for like respiratory symptoms, like you can have a family member there. But if you're coming for respiratory symptoms, or if you are known to have COVID, you cannot have any family member
contact. I see.
Unless it's an end of life situation. If it's an end of life situation, they'll kind of work with you a little bit.
Wow.
That's still tough. That's tough though.
Yeah, over here, Sean was talking last week about like he came on. He has like a 1-year-old kid, and his kid had like a cold or something, but they didn't know. They wanted to make sure, so they brought him to the ER. And the ER here, they would only let them have one parent at the time.
Yeah. That's pretty standard across the board. So those things, I think, that's probably going to stay for a while.
Yeah.
It hasn't changed.
Well, I mean, so during Christmas Day, my dad had to go to the ER. They wouldn't have any guests in the ER at all, actually, like not in the house in general.
Yeah.
So, like, I mean, they were nice enough. The nurses were super nice. They came down, took the stuff. Pretty much, we gave them an iPad so we could FaceTime and things like that. Like there was, they were very accommodating, but obviously they understood the situation. But the hospital, no visitors unless you are about to give birth. You have one parent, have the other parent in there, or that's their situation. No.
Yeah.
That's it's tough because I mean the hospital was very calm and but they couldn't break protocol in general though.
Yeah, I mean, it all comes from top down. So those are like hospital-wide policies. So it's pretty hard to mess with those. And it is hard. It sucks, because especially in those end-of-life situations, I've had a COVID, I think back to a couple instances, we got a patient that had COVID that was transferred from another hospital because they needed an ICU bed. And, most of the places in the Southeast have run out of ICU beds. So they got transferred to us. And this guy was, he had clearly said that he was a DNR, like, do not resuscitate, do not intubate, do not put me on a ventilator. But he still got sent over for, I think it was miscommunication.
Wait, who says that? Like who labels that? I'm just wondering.
Oh, so patients can do it themselves,
Oh, really?
So you can do it yourself. You could say that, if I'm in a situation where I'm not going to recover, like I don't want to be resuscitated and I don't want to be.
Really? You could do that?
Do that for yourself.
Oh,
your family can also do it for you. If you're incapacitated or not in a position to make decisions for yourself, your family can do it for you too.
Yeah, that's a tough decision to let your family. Hey, do this for me, please.
Yeah, the family.
It is, but it's so important. It is so important. Yeah.
I don't know. I could never put that responsibility, liability on my family members to do that. I just couldn't do that.
Yeah, I mean it's a tough thing, but I think it's.
I mean that's why you have to have the paperwork, right? That's why you have to have the paperwork.
Would you let your mom do that though? I'm just curious. Like, would you tell your mom, "Hey, mom, do not resuscitate me"? Like, it's so hard. It's like
no, I would because I mean it's easier for me to talk about it because I deal with it every day.
Correct. Yeah.
But I will say this: like, if you see like what end of life care involves, like in an ICU, like what
it's tough. I heard
I think it's very, very paramount that people actually talk about this and just lay it out right now. Like not at our age, because thankfully we're healthy and young, but you never know. Like if God forbid you get into a car accident,
that's true, and
they're doing all this kind of life-saving surgery and trying to like make you survive, even though the outlook is very bad. And even if you do survive, you're never gonna like walk or have any kind of meaningful like life. You're gonna have a tracheostomy and be hooked up to a ventilator and have a feeding tube and not be able to do anything. Jesus. I think it's something to think about and let your family know that
with a debt situation probably too. It probably costs a lot, and insurance doesn't cover it, things like that.
That and just like what's your quality of life? Like you want to be alive. At that point,
do you really want to be alive if you can't live? Right. Like if
that's true.
And some people do. Some people say, you know what? It doesn't matter. I don't care. Like I want to be alive. That's fine.
Can we write a piece of paper and say transfer my brain to another AI body? just freeze my body.
Freeze me like Walt Disney.
Freeze me like Walt Disney, and then in 2200 years, wake me up again.
Like freeze me. Yeah. I don't see that happening anytime soon, but I hope people are working on it.
Hey, listen, Elon Musk has been working some crazy
know.
Neuralink situation. I've been following it. I'm like, are you kidding me? I was like,
Yeah.
holy crap, it's kind of scary to be honest.
It is scary. It is that's a very scary rabbit hole.
Yeah, it's because at that point you're almost creating something. You know what I mean?
Yeah, and what are you creating?
Like, what are you creating? My point exactly. Yeah, and
what are you? If it's just your consciousness, not a.
And then if you kill it, are you a criminal now? Are you a murderer?
Yes.
Exactly.
So what do you do then? It's like, you know, like, no, because there's no, think about this, right? I mean, I don't want to get too far into the rabbit hole with this conversation, but legality wise, think about it, legality wise though.
Oh, I know. We're not, I mean, look, the government.
We're not prepared for this.
I mean, no, the government's not even, like, doesn't even know how to handle, like, social media. Like,
yeah, I know. It's crazy. I mean,
crazy.
And it's just the technology. I remember seeing a curve chart, like the technology has been evolving like exponentially while the policy has been like stagnant.
Yeah.
Right.
Yeah.
Very slow change.
Yeah. I mean, even in the healthcare sector, I mean, I'm sure you've probably seen this already. Like, I feel like there's a laggish in the healthcare, like of policy changes, probably, I feel like.
Oh, yeah. Oh, for sure. Yeah. Healthcare policy lags a lot. And, implementation of new technology in healthcare lags a lot.
Yeah. Well, I mean, because there's a lot of liability behind that, probably too.
There's liability. There's a lot of bureaucracy. There's a lot of red tape. Yeah. There's just so many legal things, and honestly, it's kind of a shame. I think it's been to the detriment of the industry. Yeah. You know, like HIPAA, the confidentiality law was never designed to do what it's doing now, what it's used for. You know, and it's such an inefficient. It makes everything so inefficient that I think if the people who like created HIPAA or really like lobbied for it, if they realized what this would do, like they would have rewritten the law.
Well, it's a repercussion. It's a repercussion of it, right? So pretty much they don't need any better. So let me ask you this though. In terms of like policy changes, right? Like obviously you mentioned that it lags a little bit, right? But I guess how I guess you even jumpstart that to kind of push that, because I feel like there's so much bureaucracy on top, but also comes from probably from like I guess the main associations stuff of that, probably like, you know, like how does it trigger down? You know what I mean? Like how will you like?
Yeah, that's a good question. Oh man, this is kind of like a different topic, but I think like, you know, healthcare is like the next big industry that's going to have like a lot of disruption, like a lot of disruptive technology.
Yeah.
There's a few like good examples technology wise. Now this isn't policy wise, but it's going to affect policy. And that is like, number one is like AI and machine learning. And like, that's going to completely disrupt things like very, very soon, like in the next 10 years. And I don't know how that's going to affect policy, right? For example, like radiologists and pathologists who do like image interpretation and like image analysis, like their jobs are definitely like on the line right now because AI, like you already use AI to do like all sorts of like image analysis, right? Like government's doing it to like do facial recognition.
Yeah,
that's true. That's true.
AI that's solving protein folding problems that has basically rendered crystallography, obsolete. Probably
I didn't think about it like that. Can you explain that a little bip more for users who doesn't understand the terminology of that? Sorry.
Yeah. So you mean in terms of the AI and how it's going to be used in medicine? Yeah. So, there's artificial intelligence algorithms and deep learning algorithms using, neural networks. So all these like computational algorithms to solve these problems. So we've already shown that you can use that to solve protein folding, which is a very big biological problem. And that it's being used in like, for example, like facial recognition, and you can train an AI to look at an image and recognize, whether it's a male or a female, as a simple example. You can do the same thing in medicine. So you can train an AI on like thousands and millions of images on, like, for example, like X-rays.
So you create a giant database of pretty much.
Create a giant database of chest X-rays, and you train an AI to know, okay, that's a tumor, that's not a tumor, that's an abnormal cell, like if it's a pathology slide, because that's what a pathologist does. A pathologist will look at a bunch of slides from a biopsy and tell you that, oh, there's like this many cancer cells, or that's a cancer cell, that's not. And it's pure image recognition. That's all a pathologist does. Like they're just trained to look at cells. And
it's almost like it's like OCR to some degree. That's
exactly. So I mean, that's completely, in jeopardy.
So what's gonna happen is like you'll take like a blood sample and then you'll put it into a computer and it'll do all of the crazy tests that normally.
Yeah, I mean, you could take a biopsy sample and just have an AI look at the biopsy sample and tell you with a reliable, with good reliability that this is cancer or not, And not only that same AI then, because it's freaking AI and it's computer, can probably like cross-reference all the medical journals and tell you like what
assuming there's a centralized database for that.
Oh yeah, exactly.
Yeah.
I mean, it's just insane, you know.
Yeah. So I guess I don't want to get too far in the rabbit hole, but obviously this has been a lot of technology advance, especially the last couple of years. But let me ask you this: obviously, because of COVID, also, right? One of the repercussions that telehealth has been sped up. I see a lot of companies popping up with their system, and they've been upgrading really fast with a lot of software releases.
Yeah.
I'm not sure if you've seen some of those. Like,
yeah, for sure. I mean, I've used telehealth.
Really?
Yeah, so we implement telehealth. Actually, I think most places are. I don't know about some of the smaller hospitals, but we definitely use telehealth. So, you know, the biggest thing with telehealth was if you go back to like last year before COVID, like let's say like 2019, beginning of, January 2019, telehealth was like, I don't even know, like maybe 1%, 2% of like outpatient.
Even, yeah,
not even that.
Yeah.
Now I think it's like almost half of primary care visits, you know, at least, you know, for Medicare billing is like telehealth, and a couple policy changes that were done very rapidly. I think these are things that the president, that the administration at that time did a good job. Like, this was a good thing. They got rid of a lot of that bureaucracy and red tape. So doctors were allowed to bill for telehealth visits the same as like regular outpatient visits.
Really? Not half? Yeah. I heard. I thought it was half. It's the same. Wow.
Yeah. At least for outpatient primary care services. Now, I mean, I don't know what it is for like specialists and things like that, but I can't imagine that it's much different, because that's one of the biggest barriers. Like, what incentive did they have to do telehealth if they're not going to get paid as much?
Right.
And,
that's true.
You know, they have to implement all this technology, like
what's the ROI for them, I guess, in a sense too. Yeah.
So, you know, I think that was a really good, smart move. Right now, the way telehealth is being used for COVID is that we do all our COVID, you know, if you need to come to the ER because you think you might have COVID, you can get screened at home. You can do telehealth at home.
Oh yeah, they're home kits, right?
We can get you tested at home, or you can go somewhere and go get tested in a distanced way. Not only that, but even for non-COVID related complaints, like we screen all sorts of patients in the ER. Like we always have, like, everything. Yeah. Like we've got like 2 nurse practitioners that sit from home and screen all the ER patients. They'll write all the orders. They'll see them. They can complete their entire visit. And if they're concerned, if it's something that like I should see, they'll tell me. They can tell me through Epic, you know, our EMR. They can tell me.
Of course, hey,
I saw this guy.
Epic changed so much. We can talk about that.
Yeah. That's another conversation.
That's another conversation there.
Yeah. So I mean, it's being used very, very widely, and it's certainly made things a lot easier. And I think that's going to continue. That ship has sailed. It should have sailed a long time ago, and it's definitely sailed.
Well, I feel like that sped up. I think one of the so I want to talk about the repercussion of COVID. I feel like also, are you surprised how fast the vaccine came?
I mean, it is. It's pretty amazing, right? Like I
think about it. Like, usually a vaccine takes forever, on average 4 to 5 years. That's what I read.
Yes, that's true.
And this is like what, 10 months?
It is. I mean, I think so. It is pretty amazing. It's pretty surprising. You know, when it comes to vaccine trials, so one of the biggest problems is like FDA rules about how you can do trials, and you know, so a lot of those were rolled back, and I think rightly so, because you know, a good example of this is, you know, this is not even related to vaccines, but one of the treatments that's being used for COVID is dexamethasone, which is a steroid, you know, and the data proving that this was an effective therapy all came out of England. You know, it all came out of their National Health Service, the NHS, because they don't have as much red tape as we do here with like the FDA wanting this and that and that.
So their research was a little bit more further.
It was so much faster. It was so much faster. They could literally do a trial on like thousands of COVID patients within a matter of months and prove that, hey, dexamethasone is actually a good treatment. And that's so embarrassing for the United States, like where we have like freaking hundreds of thousands of people with COVID. We couldn't do a trial like that quickly to you know, prove the same thing. It's just shocking. So, you know, I mean, it is kind of surprising that the vaccine came out this quick. The technology was there for a while.
Of course.
The mRNA technology has been there for like at least 7-8 years. You know, it's not that new, but rolling it out and like testing it on like 30-something thousand people. I mean, I have some issues with the Pfizer vaccine data. We can go into that a little bit. Like, you know,
I read an article that actually yesterday about this. I've been reading a lot of articles about different type of vaccines and stuff like that, but we can. I don't want to dive into that because I feel like that's another conversation to talk about.
Yeah, for sure.
But I just want to talk about, because I mean, I just want to talk about the different type of repercussion of COVID, because we've seen it in the technology advancement of, you know, working with, you know, obviously with telehealth. We've seen that with, obviously with, you know, the industry as well. But like so let me ask you this: do you think that if this type of, I guess, rollback policies for, you know, to speed up vaccine, should this be applicable for other things as well, though? If you think about it, like, you know, are they going to
keep
Oh, they're not
these?
gonna do it. They're not gonna do it.
Are they gonna push back the regulations once this is done?
Oh, you mean keep it or keep
Or
it?
they're
Yeah,
gonna keep it?
Yeah. Yes, that's a good question.
Yeah.
I am not as good a health policy expert as some other people I know, but what I can tell you is I certainly hope so. Because doing a good robust trial on like an intervention of some kind or a therapy of some kind is like such a pain in the ass that it doesn't have to be.
Yeah.
Especially when it can lead to like really, really important things. I understand it. We want everything to be safe. Everything should be like,
Yep.
all about safety and making sure that an intervention is safe. But literally some of the rules like on how you can do a trial are just so like detrimental.
Is it bureaucratic, do you think, or is it money based? You think? I'm curious now. I've been reading a little bit of both. Like,
but they get so like it's funny like to think about because like you're talking look at like pharmaceutical companies and they're getting paid to research this stuff when they get paid more to just continue researching for as long as possible instead of like coming out with something that's
you're saying purposely drag it on.
Yeah.
I mean, it really. I think that really depends on.
That's different, though. I think, yeah.
Yes, it really depends on what the therapy is, right? So, like something like a vaccine. For the vaccine, they're going to want to end the trial as soon as possible. Like Pfizer wants to end that trial. They said, "Look, we proved that it's 95% efficacy, which it probably isn't. There's no way that it's that good, But they're like, we want to end it. We've proven that it's 95% like effective. So let's end the trial. That's what they did. They're like pretty much done, and I think that's wrong. But when it comes to other things,
and I see J&J, by the way, is purposely taking their time, by the way.
Yeah.
So J&J's purposely taking their time, and they're doing retrials and stuff like that, and they haven't rolled out their own vaccine stuff like that because they don't want. I think they're thinking about a longer picture too. So
yeah.
And every company is different. Every probably would do it differently, but because of the things that, like you said, the positive rollback right now, it is a pandemic, it's an emergency situation, and so companies right now can push as much as they can if they need to, and as obviously they try to do it as safely as possible and to try to meet all the guidelines. And I mean, there's enough data out there. Obviously, otherwise, other doctors wouldn't be taking it. You know what I mean? Or nurses, they wouldn't roll this out to everybody. So
yeah. I mean, I hope it does stay. I hope that these rollbacks do stay because I think if every American should look at what Europe's doing and what Europe's done in this, and like they're
so much faster.
They're so much faster. They're just so much faster. Yeah. And this is like even they use medications in Europe, not for even COVID, like other things. They have like access to all these other meds that we don't because the
FDA. I heard surgery there is super much more advanced just because they're just the technique of surgeries because there's been done research on those. So.
They're just ballsier. They're just like whatever.
They're not ballsy. Same thing for Asia. It's the same thing for Asia.
Yeah.
Yeah. And I don't think it's necessarily ballsier. Like I said, I think it's just regulation a little bit more laid back in terms of like, okay, you can do this based on this, things like that. It's just different things to do.
We also have more of a litigation society.
For sure, that's a big part of it.
Yeah, and everybody sues everybody here.
Yeah,
so
that's an issue. That's a different issue that we need to solve.
Yeah. All right. So speaking of, repercussions though, we can dive into, I guess, the healthcare sector of the economy situation part of that, but let's take a little break. We are going to do the extra MEG session, which is the funny session. Robert, you want to start with yours and then we can jump into, Adnan, if you have a story or image to share, let us know. If not, we can,
Sure. Let me start off. I have a couple actually.
You have a couple. Oh shit!
This is the first time I have two, I think. But I have this. I thought was funny. So this guy wrote on Twitter. He posted a Twitter to the One Fresh Pillow. I don't even know this company. It's probably a pillow maker, right? And he says, just curious what your thoughts on sedition and domestic terrorism were. I need to apparently ask these things before buying bedding in 2021. And the One Fresh Pillow, they respond, clears throat, taps mic thrice. We fucking hate it.
Oh man, is that a jab at what is that guy's company? My Pillow.
Yeah,
it is.
That's pretty funny.
I thought that was hilarious. Oh, some of these companies' social media people are amazing. Like, it's
dude, like
so
I was like, Wendy's responding to people.
Yeah, like all of these like fast food restaurants, they always have good responses to people. And then I have the second one, which is a package that there's a note on their package, and it's from the Australian government Department of Agriculture and Water Resources. Apparently, they have the right to open up your packages and search what's inside, which I guess it's fine if they're like suspecting of something, right? But on it says, one of the things it says is the air courier incurs a fee from the department for this inspection. This fee may be passed on to you from the carrier. So they're opening it up, and there's a fee to open it up, and then that's gonna get charged to the person who gets the package once they get it.
That's so crazy.
Like, isn't this nuts? Like, how can they do this?
I don't know. I mean, to be fair, Australia kind of like, I mean, I'm sure they have some issues with like invasive, I don't know, is the Department of Agriculture and Water Resources, so maybe some species and things. I don't know.
I know, but like, why would that be a bill that you like that goes passed on, like an additional bill on top of your package that you're getting? Like, you're already paying for shipping, right? Like, what? Like, how is this an additional cost to just search for it? Oh man, I saw this. I was like, I can't believe this is a thing. This can't be. Oh yeah, and the comment, like the quote on it is like, "We decided to open your package. We found nothing bad. We'll send you a bill for our services."
Yeah, thanks for letting us check your package. And
thanks, Australia.
That is hilarious.
Amazing.
All right. I have a funny one. Well, technically I have two, but yeah, it's two different ones. Okay, I'll show you the most relevant one. It is an image. I saw this on Reddit yesterday morning, or was it this afternoon or something? Yeah, this was this morning for sure. Yeah. So it's an image of a package, a plastic package, I guess, imprint in it. When you take it out of the package. So it says, the title says, "My wife found the empty package without knowing what I bought." So it's a shape, it looks like a dildo shape, but it's not. It's actually a shape of the what's called the
thermometer.
The body, the scanner. Yeah. So it's
so if you look at it upside down, where like the handle is up, it definitely looks like it could be a dildo.
That looks like it's more than a dildo. That's like a full-on device.
Like a dildo attached to something. Yeah.
It's pretty funny though.
There's a lot going on there. Yeah.
I like the top comment on this. Is like, either the wife was excited or disappointed.
That's hilarious.
Awesome.
But imagine you just found that, right? You would never think about that, just a package of that.
That's true.
Oh,
you should have thrown that out.
Okay, so and then the second one is it's a whole different thing. So it's this girl playing Rocket League, and she's streaming this live, and so the title says, "Thought she noticed me, guess not." So it's pretty much maybe her boyfriend, I can't tell, but she's streaming this live, and then the game ends, and she just talks a little bit more, and then she gets up, and then literally like he's standing behind her the whole time, and she just walks away and never noticed him that he's there.
Okay. She's playing Rocket League.
Yeah.
Oh.
And if you scroll to like a minute and
let me go check my laundry.
Yeah. Like he stands there like 54 seconds, 55 seconds, He's
That's
still
amazing.
there. He's still there.
He's still there.
She gets up and leaves, and she doesn't even know.
Yeah.
Wait a minute. I'm back. Like she's like petting her cat or something, petting her puppy,
and then
she gets up. She literally walks around.
That's amazing.
This is so crazy.
He's the whole time behind him.
Oh my god.
Yeah.
That's amazing.
All right, I know you have something to share, a story. Anything?
I don't know what do you want to hear?
Anything isn't
just something funny if let's come up.
Oh man, there's a lot of funny things in the ER. Without giving away too much patient information, I feel like drug use has gone up substantially over the last month.
Wow, really?
You mean during COVID or the last month?
No, I think this is COVID, man. I mean,
is this since you've come back to Florida, or is this between the time of you come back and now?
No, I think it's new. I think it's like between the time of like since COVID started and now, especially in the last few months, man. I think I just feel like there's a significantly greater number of Florida men in Florida
Gotcha.
right now, and I don't know why.
So you
But,
see them coming into ER, you're saying?
Yeah, so anytime you're in the ER, you're gonna see a bunch of people that come in on drugs, drunk, high, or whatever.
Yeah.
But I feel like it's substantially more now.
I
And,
mean, you're at home, you don't have work,
Yeah.
you know, like
You're bored.
what are you gonna do?
I guess.
Do some
if
You
you're-
can't talk
drugs.
to anybody. You can't meet people.
know,
Can't
if
go
you're
meet
unemployed-
anybody.
if you're unemployed and you're not doing anything with your life, you're right. Like if you're not getting drunk or high, like what are you doing?
Yeah.
That's true. Yeah.
There you go. Coming from a doctor, guys. Just
Yeah.
joking.
Good advice.
No, but obviously, so you've seen a huge influx since COVID started, really?
I feel like there's a lot more psychiatric stuff and drug related stuff going on, and
It's definitely a lot of mental
Yeah.
situation for sure.
Yeah.
Though.
yeah, it sucks. It's kind of funny because it's funny when you have a patient that a guy who comes in is totally blazed out his mind on I don't even know what, like PCP, meth, whatever, to the point that you actually have to knock them out and put a tube down their throat so that you can just calm down.
Wow.
Oh, is that high?
Oh man, yeah, people do that.
Jesus Christ.
Is there
Yeah,
anything specific that you see more than others, or is it just like all around more drug use?
So, Florida traditionally has always had like more meth and more the uppers. Like
Yeah.
I remember like 4 or 5 years ago there was this thing called flakka that was like all over the place.
Oh, back in the
Flocka.
days. Oh my
Yeah,
God, that's
yeah.
so long
Remember
ago.
that?
Is
Yeah.
that what the guy was taking when he
He ate-
like turned into a zombie and started eating people?
No, apparently not. I think that's what it looks like, right? Everyone thought it was flakka or bath salts. Apparently it wasn't. I think that guy was just like, I don't know what was going on with him.
Yeah.
But yeah, no, it's interesting. I feel like there's more and more interesting drug cocktails out there now.
Mm.
All right. Well, going back to the original subject, right? The repercussion of COVID, right? Obviously, job situation, healthcare. We see
Yeah.
a lot. I see a lot of articles of hospitals, like some of the funding that they use, and they may not able to be recovered. Some of them, they can, because obviously,
Yeah.
lost revenue. You couldn't do anything during COVID time, and right now it's that. I guess from what you've seen, the fluctuation. I guess every hospital might be a little bit different, right? Because some hospital may be fully staffed and then nothing happened. Some hospital may be just overstaffed and then they had to pause those elective surgeries. So therefore they had to prioritize certain staff before.
Yeah.
Yeah.
Yeah. To sort of put this in context, and sort of give you some background on that. So if you look at like just between like March and June, or like really at the beginning of everything. So like most of the, obviously we don't have a whole lot of data for the last couple of months because it hasn't been published yet, but like ER visits, just like how many people go to the ER dropped by like 40% from like March to April compared to like the same time last year. So that's like 40%. That's massive. That's like a crazy, drop. So that means less people coming in, like less people getting admitted, like less billing, essentially, less money that the hospital is getting. That's just the ER.
What's the reasoning behind
So they did that because the reasoning is that people were scared to come because they're like, oh, if I go to the hospital, like I'm gonna get COVID. And this is
correct.
Like,
it's a mental thing too. Also,
it was a mental thing. It was all about fear. They like went and researched it. They talked to people. They're like, oh, why haven't you been going in? And actually, so forget the economics of it. Like medically, it was really bad because people were like not getting care for like heart attacks, for like strokes, like things that were actually going to kill them. Like COVID may or may not kill you. Probably not. Like statistically, it's probably not going to kill you. Like very good chance to be okay. A heart attack was definitely going to kill you. And it's not funny, but interesting that the number of like calls for cardiac arrest, like how many 911 calls went out for like, hey, like, I don't know, my father's like not waking up or, whatever, like the number of calls for that like went up actually. Jesus. And because of this, because people were like not going in to get like their chest pain evaluated, things like that.
Okay. So a lot of the preventative was dismissed, or I guess not dismissed, more like was just
there was just delay of care. People were really delaying seeking care for potentially life-threatening conditions, and the number of people getting cardiac arrest and dying went up massively, independent of like if they had COVID or not. Like it's not because of COVID. They weren't dying because of COVID. They were dying because their heart attacks and strokes weren't getting treated. Yeah. So that's pretty remarkable. As far as hospitals, like, in the first like increase, like hospitals basically shut down all their elective procedures, right? And that's what makes them money. Like hip replacement, new valve, bypass surgery for your heart, things like that. That's how hospitals make Like this, and that's just how healthcare works here, man. Like we get paid here to do stuff to you. Like that's how it works. And so all that volume went away. So they lost a lot of their money, like very early on. Like I think in the initial like half the year, it was like $200 billion like loss.
Yeah. Over I think it was over 1.4 million jobs also gone.
Yeah.
Right away for you guys for sure. Yeah. It's
so
crazy though.
Yeah, it is. It is kind of crazy. It's very paradoxical, right? You'd think that like healthcare would be like making a bunch of money or doing well during this time, and it's like totally not at all. And by June, like the volume was going back up, but it's still like
not the same. It's not the same at all.
It's not the same. And even if you project it to catch up by March or May of 2021, like 5-6 months from now, even then there's still like 2 or 3 billion lost like every month or something.
You want to hear something? Yeah. So you're pretty accurate in that. The total between March and June, it was $202 billion. And then between July and December, $120 billion, even though things are back to normal, quote unquote, at least the total over $323 billion. It's crazy.
Yeah, that's a ton of money, man.
Yeah.
It's a little bit. It's some change.
Yeah.
Some change. Yeah, if you look at the last article I just sent out by the AHA, and it's crazy the amount of money.
That's the same one I read. And the other thing you have to factor in is it's not just that they weren't seeing elective things. It's like because of COVID, some of the other costs have gone up, right? So like hospitals need PPE.
They had to offset it, right? So
they need more PPE. They need to set aside more of these quarantine areas, set up more testing sites. All these, like the costs have gone up too. Like,
the adjustments. They had to adjust for all those extra. Like even if you try to give a birth, right? You had to make sure this room's secluded or this floor secluded from COVID patient, things like that. Just to readjusting things. Yeah.
But I can tell you many, many interesting things about how that's affected the job market. For example, there's like no respiratory therapists. Like we have a huge shortage of respiratory therapists in the hospital because they're getting poached by like all these travel agencies that are like, hey, go to California, we'll pay you like $10,000 a week to go.
Oh, so they get contracts from there, and then they pay them. Wow.
Yeah. So different parts of the country are poaching each other's resources. They're like, California is like really suffering right now. Texas is really bad. So they're like, they're paying like out the ass. Like
I heard same thing for ICU nurses as well.
Same thing.
Yeah. I know quite a few nurses that have come to California because they're just
I have a couple of friends who are in Texas right now making good money in Texas.
Yeah. And then who's taking that cost, right? Who's paying them? The hospital is. The hospital that's losing money.
Correct. That's crazy how they're poaching each other's resources.
Yeah.
Now, did you ever felt like you were short of PPE stuff during early times?
I definitely felt we were short of N95s. Like that was definitely a thing because they gave us like 2 N95s and they're like, all right, these are your N95s. Like you're not going to get any more N95s. Wow. And I was like, okay. So, I mean, I didn't care because I was not like seeing too many COVID patients or anything like that. But that was kind of crazy because normally that would never happen. Like N95s are everywhere. You can have as many as you want. Like no one cares.
I mean, obviously China shut down. What are you going to buy from?
Yeah.
It made you realize the supply chain issue.
Yeah. I mean, I never suffered like they show you in some parts of the country where people were having to wear like trash bags and stuff.
Yeah.
But no, N95s we definitely had a massive shortage of.
Gotcha.
Yeah.
And I remember it took them a while to certify the KN95s to be eligible to do as well. I'm surprised how long it took them to certify that, to be honest.
Dude, I mean, it's insane. Even worse than that is like I bought my own like N95s, like reusable respirators.
Yeah.
Like I don't have a box of it. I was going to show you what it is, but it's like much more comfortable. And hospitals like were like, oh, you can't use these because we have not tested them and we don't know if it's like
certified.
Certified. And then if there's an issue, then we have the liability for it. And
it's a lot of liability. That's the thing, though, right?
Litigation. I'm telling you.
It's such bullshit, though. It's so much bullshit. It's like they want us to take the fall for this crap. And it's like, I brought my own N95. I'm going to wear it because I'm going to protect myself. I'm not going to keep reusing the.
Yeah. I worry about being sued later on.
Yeah, forget it.
And what are you going to sue me when I'm dead?
Yeah, exactly.
Yeah, seriously. Like, what are you going to do? So, like, I completely agree in that part, though. Like, and I was reading all this job shortage. Even the jobs coming back, they're not coming back as fast. Like,
no, they're not.
And they're not going to come back as fast if they're still like recovering losses and stuff, right? Like there's no way that they're going to be hiring as fast as they fire.
I guess the question is though, can a hospital go bankrupt? I guess.
Oh yeah. It happens all the time.
Like, what did they do though? Did they restructure or happened?
No. So one good example, and this is pre-COVID, is is I think it was what was the name of the hospital? I think it was Hanneman Camp. It was in Philadelphia somewhere. It was a very, very old hospital. It's been there for like 150 years, like a very like institution, kind of like almost like Brigham at Harvard. And that hospital went under because of like mismanagement of funds and like all this stuff, not having good payer mix, all the reasons that a business fails. And they failed, and they got bought by like they got bought by like a small investment firm that was going to restructure them and stuff. And then they couldn't do it, and then the hospital just went bankrupt. They shut the whole hospital down. They shut down everything. Like the residencies had to go somewhere else. Like
really?
Yeah.
Is it because so it was just people? It's just I guess the. Actually, I found who you're talking about here. Here's the article. So wait, you're right. Investment firm couldn't bring that back. Why is that? I wonder.
Because investment firms don't have an incentive to do that. Like they don't want
they probably sell the assets. That's all they did. Probably they bought it to sell the assets. To be honest.
Yeah.
That's probably what they did. It's probably just to try to sell off.
Was it this hospital here? This Hemmerman? What's it called?
Yeah, that's the one. Philadelphia Hospital. Yeah, that's
150 years service. That's fucking crazy.
Yeah, I mean that hospital is like an institution. Like everyone's heard of this hospital. Like everyone knows it.
It's like a legend.
It's a legendary place.
Jesus.
Yeah,
okay.
pretty crazy.
Yeah. So I guess so you could actually close down, and so I guess I'm wondering. I guess the repercussion of this hospital across the United States. How many of them would be shutting down because of COVID? I mean, obviously the stats have come out yet, things like that. It hasn't got to that point yet. I don't think, at least.
I think that what's going to happen to hospitals is the same thing that's happening to like physician practices, right? So physician practices, like doing private practice used to be a big thing. Like you could be your own small business, and people love that. That's slowly gone away, and COVID is going to accelerate that, because if you're a small business, you're not going to have the ability to like negotiate with big insurers. You're not going to have the ability to do all these, implement all these policies. So they're all consolidating. So people are just going to buy them up, and that's the same that's going to happen to hospitals. Like if there's a hospital that's struggling, like a big company is going to come in and just buy that hospital, like HCA or something like that. HCA is a massive system, like Kaiser, Mount Sinai, or one of these places just going to come and just buy it.
Kaiser's been killing it. Let me tell you.
Yeah, they are. I mean, Kaiser's awesome. Like, I don't know too much about Kaiser, but like,
I have a friend who works for Kaiser Corporation, and let me tell you, he loves it there. He says from top down, bottom management, it's just well handled. That's what he says.
That's what I've heard too. That's exactly what I've heard. As opposed to what we have here. Like, I mean, HCA is like, to me, I mean,
yeah, it's all different thing though. Yeah. But and I think, I guess sometimes good, sometimes bad, right? It's at the end of the day, it's a business. Like, so let me ask you, like, I guess I seen urgent care pop up a lot more during the past 2 years, especially during COVID time. A lot of them have been opening more up.
Yeah.
I think that kind of practice has been, I think that COVID helped accelerate that, to be honest. All the urgent cares, you know, talking about the little urgent cares.
Yeah, doc in the box kind of thing. Yeah.
Yeah. I seen that a lot more, especially during COVID time.
Yeah. Urgent cares have been a big business for a while. I know ER doctors that have done ER and then been like, I'm just going to start, like, I know a couple people that like own like at least 8 or 9 urgent cares, like in Orlando or basically North Central Florida. So urgent cares have been a pretty lucrative thing over the last like 10 years, because think about it. You can capture all this billing for these very simple complaints. You can even do fee for service, like very, very, very progressive like payment models that kind of circumvent the problems in American healthcare. I think urgent cares are great. And yes, you're right. With COVID, I mean, they're an essential part of all this, because they can offer on-site testing. They can even do chest X-rays. You can see a doctor, a nurse practitioner, a physician assistant, and you can get treated and all this stuff. I think for something like COVID, it's awesome.
I love urgent cares. Like
their price is fucked up, dude. They're pricey as hell.
I don't know
but they're still cheaper than your alternative, my friend.
Really?
Oh yeah.
I don't know the prices of them, but like, I've gone to I don't have a family practice doctor, so I just go to urgent care, and I barely go to the doctor anyway. So urgent care is like right down the street, and you just go in, pop in, pop out. It's so convenient.
The thing is, you can see what you're paying for, right?
That's true.
You can go up there, I'm sure you can go up there and they say, okay, like I'm coming in with like a cough. They're like, okay, if you want a chest X-ray, it's like $100. If you go to the ER, you have no idea like what you're paying for, what you're getting. Like the billing doesn't make sense. There's like surprise billing.
It's so hard. Dude, man, let me tell you, the struggle of billing. Looking at my dad's billing, I was like, what the F?
It's crazy.
I'm like, how did they can make this so much simpler?
Yeah.
Also, like you get multiple bills for the same thing.
Yeah.
I went in for like a cough, bronchitis or something, and I went to like a hospital urgent care. I went in, they did like tests or whatever. They come back, I get a bill a month later, and I'm like, all right, a couple $100, whatever, or couple $100. I was like, all right, fine. And then the next month, I get another bill for some other test that was done, and I was like, wait, why wasn't this on the original bill? And it's like, all these bills, and like I have a friend of mine who like works in the health system, right? And I sent it all over. And I was like, I already paid this bill. I don't know why you guys are sending me another bill. And she's like, oh yeah, it's just the timing of all of the billing is just completely messed up.
It's insane. Yeah. It's a joke. It's frankly a joke. Yeah.
Is it part because of the Epic system, or is it because the delay of being the inputs? You think?
Dude, I have no idea. That's a good question. I mean, I don't know. Like, I think it's just general incompetence and bad policy.
So let me ask you this: will you ever own your own urgent care centers?
Me personally, no. I'm terrible at business. Like, I know my strengths and I know my weaknesses, and I do not think I can run a business like that. You know, I know people who do, and it's just I mean, you know this because you've seen your parents. Like, running a business is insane.
It's tough.
It's just you have to be on the ground every day. Like, it's like a 3 full-time jobs, you know.
Yeah.
Getting something like that off the ground. So I don't think I'd ever do it.
I mean, you can partner with someone who's on the business side.
That's true. Yeah.
And then you would just do medical side.
I'm just not passionate about it. I don't really like. I mean, it's.
Hey,
but
I mean, I know. Look at Paul. Like, he's running his own dental practice now. You know. So.
Yeah, but that's different though. Like.
It is different though. It's a little bit more primary care type of thing, I guess. It is a different, but it's still running a business because you still have a whole staff to worry about, and you also have to worry about the marketing, and you have to worry about like all the things. Like it's definitely, I mean, obviously different industry as well, but it is different though. I guess with urgent care is like, how can you market for urgent care? You know what I mean? Like,
you can do it. It's just like I think I just don't have passion for like running a business. Like my mental energy is just like I wish I was, because then I could probably make some money. It's just not my strength.
No, I understand though. So obviously, you know, as we pivot the conversation, now with the vaccine being released, right? Do you think that, I guess, we're gonna start seeing some normality, and like, I guess, you know, things come back to normal, like at least from the healthcare sector piece? Like, do you think they're gonna, you know, start allowing visitors soon, things like that? I mean, at least maybe not this year, maybe probably at the end of this year, maybe early next year.
Yeah, that's a good question. You know, I mean, this is complete speculation. Like, I'm not even speaking from a position of knowledge.
No, that's fine.
But I think, you know, I think as vaccination will probably help normalize things quite a bit across the board. I mean, it's going to help normalize travel, right? Like, you're going to have to, like, I mean, if you can prove you've been vaccinated now, I think airlines will be able to they're still going to want to do some social distancing and stuff.
Well, for certain countries, probably they're going to want to see something like that, probably, to be honest.
Absolutely. Yeah, absolutely. Especially coming from United States, for sure.
Yeah.
So, I mean, I can see that some of the rules will be relaxed. Like, they'll say, okay, you can have, you know, maybe more visitors or something like that. Yeah. Probably elective surgeries and all that stuff is going to be normalized. I think campus will be normalized. But I don't think it's ever going to really fully go back.
You think, actually, let me ask you this. Would you think that they will make it mandatory for everybody? I'm curious.
Vaccine?
Yeah.
No, I don't think so.
You don't think so either?
No,
like, you know how TB, some certain places require TB vaccines for that, like certain countries.
Yeah, TB, and we do that here, by the way, too. It's like you have to be forced to get treated for TB, but that's because TB is different. Like, TB is like a lifelong disease that you can keep spreading, you know?
Yeah.
So that's like a bad thing. COVID is not, at least not that we know of, you know. Now, if you prove in the future that, COVID gets retransmitted and you can keep transmitting it and it starts evolving and the strains, you know, there's like there's a bunch of new strains. There's a couple that are very, very problematic right now because they might be resistant to this vaccine, or not resistant, but like be able to, their spike protein might be different, so they may not be
so they had to change, they had to evolve the vaccine as well, probably.
What do you think?
Probably will.
What do you think the probability of this vaccine creating an I Am Legend type of scenario? I feel like that's the most problematic part, right? Even if the vaccine doesn't create it, it could evolve into something like that, right?
No,
I mean,
it's a.
So I mean, can you explain the RNA technology for some people? I feel like they don't know what it is, though. If you know what?
Yeah. So so yeah, so there's a few different vaccines, right? So the Moderna and the Pfizer vaccines are both mRNA vaccines. So they contain mRNA, which is messenger RNA. So it's not DNA. It's not like the nucleus of your cell that has a blueprint for all your body. And the mRNA never technically enters your nucleus because it's sort of like a little blueprint of what the DNA is. So it never goes into your cell's nucleus. And basically it ends up into your cell, and then your cell uses its proteins to transcribe or convert the mRNA message into protein, which is the spike protein. And the spike protein is what's immunogenic, meaning that your immune cells recognize it and they start creating antibodies against it. That's how the mRNA technology works. There's other vaccines that they have, like the AstraZeneca one, I think is a adenovirus vector vaccine, which that's a technology that's also kind of recent. But basically, they'll take a virus, adenovirus, which causes the common cold. They'll replace all its like mRNA and nucleic acid with what you want that virus to make, and it's a vector, so it'll actually invade your cell, and it'll give it that mRNA or that DNA to make the protein that you want it to make.
So it makes your body regenerate that DNA.
Exactly.
That second one's more likely to create zombies.
No, I think the second one's actually been around longer, so it's probably proven that it's not going to do that. Longer, maybe the mRNA one. I mean, in all reality, I'm very, very doubtful. But if it does happen,
I don't want to be Will Smith.
The saddest scene in that movie was like the dog, man. Like
that dog.
That dog.
Sorry to spoil it for anyone who hasn't seen that.
It's been out for so long. Like if you haven't seen it, it's not a spoiler.
It's like 12 years or something, right?
Yeah, it has been 12 years. Jesus Christ. No, but the reason why I'm saying so, I know Microsoft and Oracle have been working on some kind of digital passport thing, right? And I'm curious to see if they're gonna enforce something like. So I'm in consulting, right? So for us to travel and stuff like that, we travel a lot, almost every week, but now we're not traveling at all. So I'm curious to see if clients will require their consulting to have some kind of vaccine protection to, I guess, for themselves. You know what I mean?
Yeah.
Because since we're going in and out the cities so often, would they feel comfortable consultants to come in to see them in the office?
I mean, would they be comfortable with their own employees being in there? Like that's the.
Well, at least, but they're now traveling in and out different cities. You know what I mean? You know what I'm saying?
Yeah.
At least they're going home, going back to work, going home. Back. I know where you're going with that though. Like, I feel like they're gonna probably do 50% first, and then lean back into slowly. I know certain offices don't care as much because there's the office is like 10 people, but bigger companies they do care a lot more. Obviously, yeah. I don't know. I feel like if they make it mandatory, I feel like they're preparing for that, but.
I don't think they can make it. I mean, look, so, the hospitals, our hospital has not made it mandatory. They can't force you to get the vaccine. When the vaccine rolled out,
if they have to, I'm curious, how would that go about? Do you know? At least I'm just wondering. Curious.
How would it go about if they force you to get a vaccine? I mean,
no, like how would they make it mandatory in general? Like for example, what do you have to do in order to make it mandatory? Like the CDC has to do something? What I mean,
I see what you're saying. Yeah, I mean, I think that's a very slippery slope. Obviously,
yeah.
But let's say that were to happen. Yeah, I mean, if the CDC comes out and especially if for the hospital, for example, if insurers and the people that are paying the hospital start implementing these rules, which is essentially the government.
Yep.
I mean, private insurance companies follow what the government does.
Yeah.
And the government is Medicare. So if Medicare starts saying things like, well, as part of our quality improvement and the Joint Commission, which is the oversight committee for hospitals, comes in and says that all employees are now required to be vaccinated and can't have a single unvaccinated employee. Yeah, that would essentially be a mandatory vaccination. And if you're not willing to do it, then you lose your job. So I could see that working through the bureaucratic system of hospital oversight, which is the Joint Commission of, I forget what it is, but that's what it's called.
Yeah, but I guess, but it will be definitely a harder hurdle to get through that process. Like people think it's easy to meditate. I'm like, it's a very slippery slope.
No, man. If they do that, they can't do that. If they do it, that's a big problem, and people are not going to be quiet about it. That's for sure.
For sure.
I don't think people are gonna people don't even like wearing masks. So how are you gonna force them?
How are they gonna force you to freaking get a shot in your
eye?
Yeah.
I'd rather wear a mask and get a shot. I hate shots. So it's harder to force me to get a shot or a vaccine.
Yeah.
Well, I mean, obviously, I think part of this is just to put an ease of mind of less fear, right? So people can start traveling a little bit more, be more comfortable. Things are opening back up slowly. I mean, even right now, I was actually looking at the stats. Like, even in states that are shut down, their infection is still high. And even in state that's open, it's almost as high as the states that are open. I'm like, that's kind of weird. Like, I don't know. It's just people maybe not obeying the shutdown, to be honest with you. And so, and I know that for a fact for a lot of California people, like they have secret parties all the time in LA,
Oh, really? In LA?
Oh yeah, for sure. They host like mansion parties all the time, and like there's like 200 people in the mansion,
Yeah.
and they get fined like $500 or something like that, like for having too many people there.
Yeah.
So stupid,
I mean, I think that, for example, influenza, like, which happens every freaking year and kills a lot of people. Like it does. People get super sick from the flu virus.
Yep.
And that vaccine is not mandatory, and we don't freak out about it. No one is required to get the flu vaccine to travel, and people catch influenza, they die from it.
Yeah.
COVID, has a mortality rate of maybe 10 to 20 times more than influenza. So it's still pretty small. But I think it's because like it's just happened all of a sudden, and it's because it's this new thing that we haven't had before. It's all at once. So everyone's like freaking out about it. And I get it. I agree that.
Well, this is the first time the United States has reacted to a pandemic ever, to be honest.
Ever. Yeah, exactly.
Yeah.
But
Asia are used to it. Asia, not the world.
Asia's used to it. Exactly. They're used to it.
Those Europe's used to it too.
Yep.
Yeah. So we're more prone to that, and I think because of our society or culture, we're more instead of more of a collective community, we're more individual here. So so everybody's reacting reacting differently.
Yeah. Yeah, I agree.
And it's an interesting take, but you're right. Though. I think to make it mandatory is definitely a slippery slope, though, for sure.
Yeah, I love the vaccine. I think the vaccine is great. I have no fear of any kind of long-term side effects from it. I get into arguments with anti-vaxxers all the time. I think that's a bunch of BS, but at the same time, there are lines that you can't cross, and making it a mandatory thing.
Let me ask you this though. Then, so what are some of the long-term research you want them done for these vaccines? Then I'm just curious. Like,
I just want them to do basically just keep track of the people that they vaccinated. So for example, let me pull it up because I was looking at this earlier.
Because I read today in California about 300,000 vaccines had people had at least according to them to be tracking had side effects.
No, they said a batch of it was causing some sort of side effects, and then they stopped those 300,000.
Correct.
Yeah.
So it's not 300,000 people that they're tracking. It's like a certain amount of people in that batch, right?
Right. Yeah. Right. And I mean that I'm not too worried about the side effects like headaches or nausea. I mean the side effects that matter is like anaphylaxis. So like you're having a straight up severe allergic reaction to some component of the vaccine.
Yeah,
I think that's what it was. That's what it was.
Yeah.
There have been some cases of anaphylaxis. Yeah, so that obviously is a big deal. But that really comes down more to like probably what the vaccine was like mounted on, and like what the other components of the vaccine are than the vaccine itself. Yeah. But I think the biggest thing that people are freaking out about, and this is what I get asked about all the time, is long term. Like, am I going to have something 5-6 years from now?
That's true.
10 years from now, because this is a new technology. To use mRNA, is it going to do something to me? Is it going to cause cancer? Is it going to cause, I don't know, whatever, And
my parents are not willing to get it, to be honest.
Yeah, I don't.
Mike Wong's not willing to get it. That's like, because of the same idea of like no research, right?
It's not even that. It's not even that. I told, like I said, if I need to get it, I'll get it. I mean, I'm not really against it. I mean, I've gotten plenty of vaccines. Trust me. For South America, let me tell you, plenty of vaccines. So
is what I'm saying. You're saying if you're forced to get it, you would get it, but like that's not saying that you like trust it at all.
Well, I mean, will you get it? Will you get it, Robert? Though, let's say that you need to get it for your job.
I need to get if you force me to get it, of course I'm gonna get it. That's not like
let's say that your job recommends to you, right? Recommends to you to get it. Will you get it? Like not force you, they say recommend it.
I probably won't get it until I need to go see somebody else. Because right now I'm at home.
Yeah.
I'm not doing it. I don't see anybody. I went outside yesterday for the second time since Christmas, right? So I don't see anybody. There's no reason for me to get the vaccine right now. Once I go and start like visiting family or going out and doing stuff, then like the vaccine, I'll be totally down to get it.
You would not let your mom visit you then?
My mom?
Yeah.
No, I would force my mom to get it because my mom goes and does all kinds of crazy stuff. Like she's always out and about.
But your mom's a nurse. She doesn't take care of herself.
I guess so, but like I don't know.
What I mean? Like she doesn't take care of herself.
I don't know.
I mean, my parents
I feel very.
My parents are the same thing. My parents are all out about. They're trying to fix their house and stuff like that. So they go to Home Depot almost every weekend and all the things like that. Like they live life. They're like, you know what? I wear my mask. I wear my glove. Things like that. They're preventative about it, But like I live my life already.
I know. I get it. But if I'm gonna see people, I'm gonna take it just because I'd rather not have the hassle. But right now, I don't see anybody, so I'm not gonna take it because it's
Yeah,
just a
no,
waste on me.
that's
It's just
fine.
a waste of a vaccine because I'm not gonna
Well, you're not allowed to
get
take it right
infected.
now, regardless, though.
Yeah, right now I can't take it, but even if I
Yeah.
could, I wouldn't right now because other people need it more than I do right
Oh,
now.
hey, I know. So you heard about the shelf life for that, right? The shelf life is like 5 days once it's out of the what's called the.
Yeah, the reason for that is because the mRNA is enclosed in like this phospholipid membrane
Yeah.
thing, you know. So yeah, it's very unstable. It has to be like very very cold. But the
Yeah.
Moderna one apparently doesn't have to be stored that way. I'm not sure how because like
Yeah.
it's kind of the same technology. But yeah,
Yeah, because one of the biggest issues that once they open it for everybody, I think supply chain is going to be an issue because how they can distribute it, and because you only have 5 days shelf life for that,
Yeah.
and then we are wasting it, and then people are going to be pissed if they start seeing reports of being wasted, those vaccines being wasted
Yeah.
because they're not distributing fast enough.
right.
And so I think it's going to be an interesting take to see how that turns out because pretty much right now we're running a blank check to those companies.
Yeah,
Yeah,
If you think about it, like it's a giant blank check from the government to those companies.
yeah. I mean, I think it's gonna change, and maybe they can make that technology a little bit better. Plus, you have like all these alternatives, so it's not just Pfizer. You still have Moderna, you still have AstraZeneca, you still
Yeah.
have like, J&J are working on theirs.
Yeah,
So I think
it'll get competitive for sure.
yeah, I think the bigger concern is for other countries. Like how are you going to distribute a vaccine like this in like third world countries that are
That's
seeing,
true. How you gonna move that?
yeah,
Yeah.
yeah. Which is where like the majority of the population of the world is. So you can't just ignore that population. You can't just be like, oh well, screw
Yeah.
them, they can figure it out.
And we just recently signed a big stimulus package for AIDS for other countries too.
Oh really? I don't know about that.
Yeah, it was during December. It was one of the.
Oh, that big. But we always do that. We always like.
But it was more than usual though. The
Oh really?
Yeah, it was a huge.
Yeah.
I was like, how can you do that and not worry about it as much as here in the United States? Like I don't know.
Yeah.
That's just crazy though.
Also, I have a question about like how are they going? Like, are they working on a way from getting it from 2 shots to 1 shot?
Yeah,
That's a really good question. That's a very good question.
I heard
yeah,
J&J's working on that. J&J.
Yeah. So I mean, the data. I think it just needs to be studied more because I think they showed that. Like I think the AstraZeneca, no, the other one, maybe I forget which one, but like you could actually at lower doses with the first one, you had like less transmission rates, even though so they gave lower doses for the first one than they did all these like subgroup analyses. So I think to summarize, like there will be more studies. They will come up with a dosing regimen that potentially you could just get one, and that would be just as effective as getting 2 doses. Right now, everything they've done for all these vaccines, for Moderna, for AstraZeneca, and for Pfizer, all of them are 2 doses.
Yeah.
And I think they're just trying to be careful. They just want to make sure that you mount an adequate immune response because it takes weeks, right? It takes weeks for your body to recognize that protein and make the antibodies to it. It's not a very quick thing at all. So I think they just want to be like extra sure.
Yeah, maybe I'll wait till there's 1 shot.
One shot.
I'd rather take 1 shot than 2. Also, for the like third world countries, it's easier to just do a 1 shot per person versus like having them come back. Like who's gonna come back?
For sure. I mean, from the
shot?
medical side of things, I would much rather it be 1 shot because the compliance is much better that way. You don't have to worry about ineffective dosing.
That's true.
Yeah.
And the misbalance too. Yeah.
Right.
So I just sent you guys sent you the J&J report thing, how they were showing some promise in the early stage trials of 1 shot.
Yeah.
And so you're right. They talked about how make sure the long lasting immune response is long enough, safe enough, is generating, like you said. So, but yeah, they talk about that. How they track of the antibodies, means how long within how many days, things like that. So.
Yeah. I mean, one problem I had with the Pfizer trial was that they're only tracking like the participants for like 2 or 3 months, like after the vaccine.
That's it?
Yeah, that's it. And
very short amount of time.
Yeah, it's a very short amount of time. I think that's a big problem. And, that's probably because number one, I don't think their efficacy data is as good as they think. And I'm wondering.
They're like, we gave it to them. They're not sick after a week. They're good.
Exactly. Pretty much. They're like, all right.
Like, we found it. It's a cure.
Success.
I mean, I can see this being a yearly thing, right? But like you said, the immune system might not respond to like for example, like I mean, obviously, even if you get COVID, right, you're only immune to it for a certain amount of time, and then you can get it again, apparently. So
yeah, that's true. We don't know who gets it again and like how often that happens, but it does happen. That much we know.
Yeah. So there's not enough data with that.
No.
And so, and in terms of like vaccine, like the immune could wear off, to be honest. So
yeah. I mean, it does for influenza, and the influenza vaccine when you get a flu vaccine, it's like 20 or 30 like different vaccines, like kind of in a cocktail, because there's this thing called antigenic drift where where the virus changes like year to year. It comes out in different different combinations of proteins. So who's to say the same thing's not going to happen here?
That's true. Yeah.
That's what I assume is just going to happen. It's going to evolve every year.
Yeah.
Hey, flu shots are free. COVID shots can be free too. So.
Probably.
No, seriously. I mean, I'm like,
probably.
I remember last time I was telling Robert on the last podcast, like, I think the last time I got a flu shot was like 10 years ago because I needed a free movie ticket.
For a free movie ticket. That's why he got it.
That's awesome.
And I have friends who are convinced that the flu shot gives you the flu, or like it gives you full on the flu.
Right.
Well, because it probably is a reaction to the body. I mean, the body's probably just reacting.
Yeah. I mean, I tell patients that all the time. Like, it doesn't give you the flu. You don't get influenza, but you get sick. You get a fever and you get a cold, so you think you have the flu, but really you don't. And
I remember I got chills from it one time. That's about it. And then it went away the next day.
Is that the movie ticket one?
Yeah.
So that's why
it's worth it though.
Stop.
It was worth it.
You know what's amazing to me? What's amazing about this is that like I've seen like zero flu like all year, zero. And it's because of all this distancing and like the fact that like people are like super.
It's not zero. It's a lot less for sure.
It's a lot less. It's not zero, but I personally have not seen any cases of flu. Whereas normally I'd see like at least like a dozen.
Well, school wise, especially school work, I remember used to go in their client, and then they had during the flu season they had 2 giant bags of Halls and whatever, and then vitamin D and C just in case they get sick. You just grab and go.
Yeah.
Because they knew they're gonna spread that,
That's the champion's formula right there, man. Halls and some vitamin C.
That's what it is, though, for real.
Is it that there's less flu, or is it that the flu is being diagnosed as COVID?
It could be both.
No. It's less flu because we have a different assay for. So if you're getting admitted or you're getting evaluated for viral complaints, we obviously we're testing for COVID, but if the COVID's negative, you're right, we're not necessarily testing for flu as much. Maybe that could be it. But if you're getting admitted to the hospital, like we're testing you for everything. For all the other viruses, and early on there was a theory that actually having COVID like makes you more likely to have other like viral infections, like a co-infection. That was what some of the data was out of China, but I don't know if that's actually like really been demonstrated here. So I don't know. It's kind of interesting. I'm not sure if the jury's out right now. I think.
Yeah. Well, I mean, we'll see. I'm sure, when this episode airs, and then things can change. When we watch this episode, probably a year from now, we be maybe in COVID, 2021 or 2022, or maybe Robert be, the only Will Smith alive,
Oh my God, I'll be the only one left. I'm making a podcast for myself.
Right? I'm just kidding. No, but I feel like you're right. I feel like this probably will be like what's called an ongoing thing every year. Is probably going to evolve, not going to disappear overnight. And the question is, though, people, how they're going to return back to a sense of normalcy, in a sense, to be honest. So.
Yeah, I mean, if you remember SARS, like SARS and even MERS, like they went on for years.
Yeah.
Like that went
easily like 5 years. I remember
easily. So I have no reason to suspect that this is any different, even with a vaccine. Because like you said,
did they ever create a vaccine for SARS? I don't remember.
No, I don't think, not that I know of. I mean, if they did, that's pretty awesome. But but even with a vaccine, if you don't have a sufficient number of people vaccinated, or if the virus evolves and you have to get revaccinated and you don't, and then social distancing, like all this stuff kind of relaxes, then I could see it going on for years until things kind of calm down.
Let me tell you, dating is hard, man. COVID, I'm telling you, it's been hard.
Dating?
That's all I care about right now. Dating is hard.
Yeah. I mean, you just gotta get creative, man.
It's in general. I feel like as we get older, meeting people is just harder. So.
That too.
All right, so we're gonna end this episode with the rant. So pretty much what we do is the venting session. What we do is called the free range venting session. So whatever you get off your chest, let it go, so that way you start off the next day, more, just more relaxed, So Robert, what's your rant?
Oh, my rant. Come back to me. I remember I had one. I just didn't write it down, so I don't remember what it was.
Do you have one, Adnan? Do you have a rant or event that you want to just let go? Or something that annoys you and you just want to say it?
Man, people. I mean, I'm like a rage driver. Like I rage a lot. If you ever drive with me, like I yell so freaking much. Like it actually is like a cathartic experience to me, and I get so angry.
You're Florida driver, pretty much. Okay, got it.
Dude, like so much stupid shit people do here, especially being back in Gainesville. Like I just can't stand it. Like
Kids.
Yeah, it's just like actually. So this is horrible. There was an accident the other day, like a really
Oh
bad
yeah, it's a really bad accident on 13th Street, right? No, University, right?
on University.
That's what I read. I read somebody passed away.
It was bad. It was bad. Yeah, there was
Like, how bad was it? Can you describe people who haven't heard about this?
Yeah, so there was an accident, and again, it's because the college is back in session. There's a college bar called the Social, that's right across from campus, like literally right across from campus. You can just walk across and you can go to this bar, and it's a hot spot for the undergrads, you know. And it was Saturday night, so obviously you have like a crowd of people out there that are piled onto the sidewalk, you know, waiting to get in. That's how it is. It's been like that for years. And there was a car that like ran a yellow, and then someone didn't think he was going to run the yellow, so he T-boned this guy, and the car that got hit spun, and it spun and hit this crowd of people, like hit like 5.
It killed 4 people, right? Didn't it?
No, it killed 1 person, and it seriously injured the other 2. And you know, they were in the hospital. I was actually working when this happened, but it's just so frustrating because, you know, I go up and down University, and the problem is that you got all these kids, like a lot of them, like these freaking rich kids.
And they walk in the street too. They're walking the street drunk.
Yeah, they walk the street drunk, but like, you know, to these students' defense, they were just standing on the sidewalk waiting to get in. They weren't doing anything wrong. Like but these drivers just like, people drive so rough on that road. They're probably driving drunk. I don't know. And it's you know, you're 18, 19. You didn't pay for this car, but you think like everything's replaceable, and you just drive like, you know, you just drive like total, you know, crazy person. And it's all over the place. Like Gainesville has like extremes. Like you either drive like that, where you think like literally nothing matters, and I'm going to drive 80 down University, or I'm going to drive 30 on 39th because, you know, why would I go any faster?
they haven't charged what's called traffic homicide yet. That's crazy.
Yeah, I haven't actually checked up on that to see what the updates have been, but it's just a tragedy. It's a big tragedy. It just sucks, you know, because these were young students that were 18, 19.
Yeah, it's what a shitty way to start.
They didn't do anything wrong. They were just standing to get in, you know.
Yeah.
Wow,
we've all done that. I know all of us have done that here.
We've all been
Dude,
the same
I know
situation.
people who walk drunk on the street there.
I know.
Seriously.
I mean, you remember this. You've been to Gator City. Remember Gator City?
Yeah.
This is where this was. Like,
that's scary though, too. Just not to see that coming, to be honest. So.
I mean, 100%, man.
And you can't react to that.
No.
Yeah. Oh my god, that's crazy.
Yeah. Robert, do you remember your rant?
Yes, I remember now. My rant is that I'm on TikTok too much, and I need to stop.
Did you delete the app?
I have not deleted the app, but I'm going to. It's gonna be.
You should just put screen time. Yeah, just put a screen time on that timer.
I don't think I ever follow that stuff. Like,
no, like they warn you in screen time timer. You spend too much time on that.
No, and TikTok. If you scroll enough, they'll be like, "You've been scrolling a long time. You should stop." They have
how
those.
Long do you have to scroll? How long do you have to scroll for that to come up?
I don't know. Probably like as long as I've been on there.
They warn you?
No, every once in a while they'll have like a commercial that's like, "Hey, you've been scrolling for a long time. You should go out and take a walk or do something else."
Make you take a break.
Yeah, take a break, go to sleep. Like they said, like it's like I don't know whatever the commercial says, but I remember I always swipe past it because it's like, oh, this is a commercial again. But yeah, so like the same thing happened when we had Facebook, right? Like I would have the Facebook app on and just keep scrolling through and just seeing what people are saying.
No, but TikTok AI though, let me tell you, it's crazy. The TikTok AI.
All of these social medias do the same thing, right? Like
but
Facebook does it. I did it for Instagram. Like I had to quit Instagram for a little while because it just was too long. So like TikTok is getting on that level where I would just start scrolling through, and it's bad because I'll be like super tired. It'll be like 1 or 2 in the morning. I'll be like, I'm going to bed, and then I'm in bed and I'm like, you know what? Let me just look at one video, and then it just gets
not a video.
3 a.m., 4 a.m. I'm like, oh god, now I can't wake up the next morning.
You know, you should just read a book before you go to bed. That's it, man. It solves the problem.
Yeah, but they don't have like funny videos on the book. So yeah, so like I'm pretty sure I'm gonna start like cutting it off and just like I've deleted Facebook already. I'm probably gonna delete TikTok soon. Instagram's still on there. I just don't ever go on. So I got to a point where I just don't go on Instagram anymore. So that's good.
I don't think I ever scroll on Instagram. Just like on the discovery page at all, to be honest. TikTok.
I don't do a discovery page either. It's all like the main page.
Your feed.
Oh, the feed.
Yeah, like that feed is like all of those feeds. The unlimited scrolls are horrible.
The only thing I look at maybe Instagram is just the people's story. That's probably really it.
That's what I do too.
Yeah, but with TikTok,
I didn't know about stories for a long time. watch that stuff.
So like with TikTok though, I do scroll down for certain things I want to look for because I search for the hashtag. There's actually a lot of good entrepreneurship stuff there, which kind of like it's pretty nice to see. And it's like shortcut things like that. And if you use it right, but let me tell you, the reason why I'm talking about TikTok AI, it's much better than any other platform. And it's like started feeding you certain things that's linked to that sector. Like for example, I was looking at digital marketing for small entrepreneurship, thing like that. And then it started linking different tools to that, related to that. And it wasn't because of the hashtag, it was just because it was feeding that exact, and then from that tool, it linked to a strategy, things like that. And it just kept feeding on. And it kept, like, yeah, it's crazy. Like the AI is definitely, they're doing something different for sure.
I just scroll and I just keep scrolling. I'm like, I'm gonna find one more funny one. That's it. And then I'll scroll through, and then I'll find the funny one that I was like waiting for. And then I'll be like, oh, just one more. And then it's like 3 hours later, I'm done.
Sounds like you're talking about heroin, man.
I know,
Yeah,
it's
right?
too much. I gotta get rid of it.
I have that issue with Reddit because I was reading a lot of Reddit memes and stuff like that, funny stuff like that. So, and then you get into a rabbit hole with Reddit.
Thank God I never got into Reddit. Because that, I know for sure I would do the same thing.
Yeah.
Like I remember spending hours in the morning just waking up, just going to Reddit. Okay, let's see Gainesville Reddit, whatever it is, what people talk shit about, or Orlando Reddit, what people talk shit about, and stuff like that. And then you look at the funny things, what happened, But now I think you follow a lot of Instagram stuff, like something like influencers in the wild. You get all these funny videos, things like that. But I know, but I try to control it now more because I do have the screen time warning. Like, hey, you've been on this app for 15 minutes now. Get the fuck out,
Right.
I would never follow it. It would say it, and then I would just be like, all right, thanks for telling me. I'll just keep going.
Oh man. All right. My rant, it's not, I guess it is a rant. It's more, I guess, I don't know. I'm more annoyed. So I've been running a lot more. And today I tried to do a new PR on a 3-mile run. Man, I did not make it. I was like pushing for it too. I was just mad. I was like, I felt good the first mile, and I felt good the second mile, and then I started feeling like a little, I guess, hamstring tightness. I was like, no. I'm like, no, there's no way. So I'm looking at my clock. I'm pacing well.
You're powering through.
I'm powering through, and then maybe almost like I say probably like 2.5 miles, I start slowing down dramatically. I was so mad. So I obviously didn't get my PR today, but I was like, but I've been working on it the past 6 to 7 weeks already. And you would think by now I would have improved more, but I was just mad today. That's all.
Dude, I totally get that. Like I've been trying to run like as well because I just need to do cardio and like lose some weight. Like I want to be able to run. I want to be able to run like 2 miles like comfortably, Like I feel like I should be able to do that. It's
especially at our age.
At our age, I'm not asking that much, but my body just freaking hates it, man. I just can't run. I'm not a runner. I just can't do it. I can't even do a mile right now. I get to a mile
straight. A mile straight.
Something. Dude, I get to like 3/4. Like, oh man, everything hurts. Like my leg hurts, my back hurts.
I can't breathe, especially the cold air.
Mike, I totally feel you. Every time I want to run, I get annoyed too. Same thing. Just the thought of running, I'm like, oh, I'm so annoyed. So.
Yeah.
Just the guy who used to do everything in high school.
Oh man, high school I was all about it. Not anymore.
No, but I mean, we're not getting any younger. So I was like, you know what? I'm gonna push for it, So my goal this year, obviously, is like I'm trying to do a workout at least minimum 15-20 minutes per day.
I saw that.
And then my goal is at least to have an average heart rate of 130 BPM, at least get that up there. And it's just to get up just because I feel like it's easier to slack off, especially during COVID time. You're still working from home by yourself. And what I mean? Like, I'll do this tomorrow. And there's no accountability. No one's around you, things like that. So like, so you know what? I'm just going to try to switch that a little bit this year. So
what's your goal with that? Is it more like the goal is commitment to prove the commitment?
It's commitment, change of habits. So remember I did the 365 push-up, that one. Let me tell you, it was hard. It was more of a mental challenge thing than towards the last quarter of the year. It was just push-ups. I was like, I'm so tired of push-ups. I hate push-ups so much. I was like, and then only that, I wasted time on recording the push-ups and then editing the video of the push-ups.
I remember.
I remember for a month, maybe for 2 months, was 300 push-ups every day. Remember that?
That's crazy, dude.
Yeah.
That is crazy. That's no joke. That is not a small amount of push-ups.
So I felt like, you know what? At least with this is not going to be harder than push-ups because it's consistent and it's not like I'm adding more minutes to something like that,
Yeah.
So this is just to show that I can create a new habit from scratch. I can stick to it. That's all.
Yeah. I love it, man. I love it. I think it's a great idea.
Yeah, we have a couple of people. Sean's doing it. So Sean's trying to do that. He says that he wants to get obviously some of he got a Peloton, so he's trying to do Peloton once every day.
Yeah.
He's been doing it. He's been doing it before even this challenge.
Yeah.
He was doing every day, so
Yeah.
he's loving it.
Yeah, and obviously he's trying to get back in shape and stuff like that, so which is good for him though, especially like indoor stuff. So yeah. All right. Well, listen. Hey, we're gonna wrap this up. So Adnan, you want to pick anything?
Do I want to what?
You have anything to pimp?
Anything to pay? Oh yes. So I mean, not really, but but I do have a website. That's em2ccm.com, and it's really geared more towards like medical professionals. But if you're interested in emergency medicine and kind of the intersection of that and critical care, I write about that. I'm trying to.
Is it a blog? What is it?
It's kind of like a blog, like a personal blog.
That's pretty cool, man.
Yeah, so it's an ongoing project of mine, and hopefully I'll add some more content. And I'm going to try to have like a few other things in there that are non-medical.
Let me ask you this: do you try to do this every week, every couple of months, every couple of weeks?
So when it started, I was trying to have like some good posts like every couple months. And if you look at it now, I haven't posted since like 2018, and part of that's because things got busy. But I do have a lot of content, like ideas and things, because it's a very new space. EM and critical care combined is like only in the last 10 years that's really developed. So it's really geared towards sort of making it easier for people to learn about that and transition into that. Because when I was doing it, I had no information.
Gotcha.
Wow.
So I guess who would be your typical audience? I'm just wondering. Like
probably like medical students and emergency medicine residents. So if anyone like that's watching, I think it's a reasonable.
So are you writing it from more like a personal experience type of deal what you dealt with, or more like from a scientific, like from a more, I guess, like a science standpoint? I'm just wondering, like.
No, it's more of a personal experience and kind of a guide. And for example, I talk about interview questions that you might get asked when you apply for a critical care fellowship when you're coming.
Gotcha. Oh, that's pretty cool to help that. Cool. That's good help. Yeah.
So yeah.
Awesome. Yeah. Gotcha. So check out Adnan at what is it? emtoccm.com. I have it up on screen here. People.
Work in progress.
Yeah, check them out.
My mind.
Don't worry, I know we'll talk about more about this. I'm really curious. I feel like there's a lot of value that this could be added for sure, especially like because I even struggle when I want to find some of these stuff, like it's hard. Like it's really hard.
It is. Yeah.
Yeah, true. All right, yeah, check them out. And then for anyone watching on YouTube, go and smash that like button and subscribe to our channel. Write down any comments that you have for us, any questions that you may have for Dr. Adnan here. And anyone listening, leave us a review or send us some comments on your podcast app, whichever one you're using, iTunes or Spotify or whatever. And don't forget to check out our website, gfothoughts.com, for all of our episodes. They're up there. Thanks for joining us.
Yeah, until next time. Thanks, Anna. Thanks for your time. Appreciate it.
Thank you guys for having me.
Take it easy.
Peace.
Thanks for joining us for this episode of the Gluten-Free Organic Thoughts podcast. As always, we appreciate you. If you are watching us on YouTube, please don't forget to subscribe to our channel, like this episode, and leave us a comment. If you are listening to us, please leave us your honest review on your preferred podcast listening platform. And as always, you can find us on social media at Facebook, Instagram, and Twitter at GFOT Thoughts. Drop a comment and give us some feedback. We would love to hear from you. Until next time, see you then.